Good afternoon, ladies and gentlemen. First, I would like to thank for the APASL steering committee to choose me for this great award. Today, I'm going to talk about the cirrhotic portal hypertension, pathophysiology assessment, and clinical implementation. I have nothing to disclose. Let's see the pathophysiology of cirrhotic portal hypertension. As I have shown you in this morning's, the classical hemodynamic derangement in cirrhotic portal hypertension is from the hepatic fibrosis from coronary liver disease. The increased intrahepatic resistance is the initial phenomenon for increase in portal pressure. Thereafter, there is splenic and systemic circulation, vasodilatation of the systemic and splenic circulation, and ultimately lead to hyperdynamic circulation. And the hallmark of this hyperdynamic circulation is increased cardiac output and splenic blood flow, and also decreased systemic and vascular resistance and mean arterial pressure. As I also show that there's an increased endotoxin in the blood in cirrhotic patient, the endotoxemia is increased in relationship to the severity of liver disease, and also the systemic vascular resistance is lower in patients with endotoxemia. We all know that bacterial translocation is an important phenomenon in cirrhosis, and from the animal study, the cirrhosis with society has a more positive mesenteric lymph node by bacterial culture, and in human with cirrhosis, the positive culture rate is also increased in association with the severity of liver cirrhosis. It is well known that bacterial translocation occur in cirrhosis. This may be due to the alteration in gut microbiota, dysfunction in intestinal barrier, and also the impaired immunity of the gut. It has been shown that endotoxemia has been play an important role in cirrhotic portal hypertension. It is known that the portal hypertension, bacterial translocation and endotoxemia is contribute to the development of portal hypertension and splenic circulation, and it also contributes to the immune derangement in cirrhosis, and also may be closely associated with the variceal rebleeding. And in cirrhotic rats, we have found that using antibiotics, ciprofloxacin to suppress the endotoxemia may ameliorate the hyperdynamic circulation and decrease portal pressure. In human with cirrhosis, intestinal decontamination will also ameliorate the hyperdynamic circulation and portal hypertension. So let's see some example of the inflammation in the complication of cirrhosis. Cirrhotic cardiomyopathy is a well-known phenomenon, and it is the hallmarks impaired diastolic function and systolic function with decreased contractility. Our previous study have shown that the endotoxemia will affect the macrophage and lead to the signaling cascade to increase tumor TNF-alpha and the signaling cascade, and ultimately lead to the beta adrenergic hyporesponsiveness to cardiomyocyte. In addition, the activated macrophage will also increase the endocannabinoid system and also increase oxidative stress. They all will act on the cardiomyocyte to lead a hyporesponsiveness of beta adrenergic blocker, and ultimately lead to the decreased contractility. And classically, it is well known that the cirrhosis will ultimately lead to the renal dysfunction, the previously so-called hepatorenal syndrome. And classically, they all say that this is due to the hypoperfusion of the kidney in the circulatory dysfunction occurred in cirrhosis. However, from the animal study, we found that in endotoxemia, the animal with lipopolysaccharide, they have reduce the continuous flow or even no flow in the microvascular region in the renal peritubular vessels. And this have been suggested that the decreased blood flow in the peritubular vessel may lead to a sluggish blood flow and lead to the danger particle, the damage and the pathogen associated molecular pattern to go through into the tubular renal tubule and initiate the inflammation process, and that ultimately lead to the tubular damage. So currently the mechanism for renal injury in AKI has been proposed in addition to the renal hypoperfusion, inflammation with dam and PAMPs, and the microvascular dysfunction and direct tubular damage all contribute to the renal dysfunction in cirrhosis. And we'll make a brief introduction of the hepatopulmonary syndrome. It is the intrahepatic vascular dilatation and the intrapulmonary shunting, intrapulmonary vasodilatation and intrapulmonary shunting in portal hypertension. And the hallmark is the hypoxemia in patients with cirrhosis. In our animal study, we have found that in the bronchial alveolar lavage, the M1 macrophage is significantly increased, and the inflammatory cytokine TNF-alpha and MCP1 is significantly increased, and also in the lung tissue, the TNF-alpha is significantly increased. However, this increase can be ameliorated by the administration of thalidomide, which is the anti-TNF-alpha agent. After correction of this inflammation, we can see the arterial alveolar oxygen gradient was decreased, indicating they were improved in the development of hepatorenal syndrome. So although the hypoxemia in hepatorenal syndrome is multifactorial, but the endotoxemia is still an important role for the contributing to the hepatopulmonary syndrome. It is well known that the hepatic encephalopathy is classically is caused by the hyperammonemia, and clinically we still use the lactulose or certain agent to decrease the ammonia level to treatment of hepatic encephalopathy. In a nice animal model, recent studies show that the chronic hyperammonemia in rats will lead to the elevation of the TNF-alpha and the decrease of the anti-inflammatory cytokines. In the same time, the microglia become activated at this stage. And this phenomenon can be ameliorated by the administration of infliximab, which also anti-TNF-alpha agent. So hyperammonemia and in cirrhosis may lead to the peripheral inflammation and ultimately lead to neuroinflammation and altered neurotransmission and lead to the development of hepatic encephalopathy. Cirrhotic cardiomyopathy is also, cirrhotic sarcopenia is also an important complication of cirrhotic portal hypertension. Currently, it is well known that sarcopenia is associated with poor outcome of patients with cirrhosis. In our animal study, we found that the anterior tibial muscle weight and the gastrocnemius muscle weight is significantly decreasing in bile duct ligated rats. However, these changes can be improved by the administration of thalidomide. So the sarcopenia in advanced liver disease is also multifactorial, but endotoxin and endotoxemia may contribute to the inflammation of the muscle tissue and lead to a decrease of muscle mass. And so currently we can know that the portal hypertension may lead to the bacterial translocation and lead to activation of the innate pattern recognition receptor and lead to pro-inflammatory cytokine to release. And these will lead to the inflammatory process and finally lead to the cardiopulmonary dysfunction, hepatic encephalopathy, kidney dysfunction, and the ACF or sarcopenia. So I think the current concept has been changed from that the cirrhosis with portal hypertension can be regarded as a systemic inflammatory multi-organ syndrome. As portal hypertension is the major cause to develop a various complication in cirrhosis, so assessment of portal pressure is important in patients with cirrhosis. We know that measurement of hepatic venous pressure gradient HPVG up to now is still the gold standard for evaluation of portal hypertension. Many years ago, our group and also the Spanish group have found that the hepatic venous pressure gradient correlated very well with the wedge hepatic venous pressure. Wedge hepatic venous pressure is correlated very well with the direct puncture of the portal vein pressure, and in both hepatitis B cirrhosis, HCV-related cirrhosis, and also ARCO cirrhosis. So I think the measurement of HBVs can reliably reflect the portal pressure in patients with cirrhosis. And the measurement of HBVG can reliably reflect not only the degree of portal hypertension, but we also can measure the systemic hemodynamic status in patients with cirrhosis. HBVG increase in the progression of the severity of cirrhosis, and the systemic hemodynamic parameter, including cardiac output, is also increased, while the mean arterial pressure and systemic vascular resistance is decreased associated with the severity of cirrhosis. So HBVG can be used in the clinical implication. The prognosis significance have been reported for many years, since many years ago. It is well known that when HBVG greater than 10 mmHg is we call it reach the clinical significant portal hypertension. When he above 12 mmHg, it will induce variceal bleeding. And in that decompensated cirrhosis, various degree of HBVG may also predict the poor outcome in this patient. Another important clinical implication is the measurement is to evaluate the pharmacology effect of on portal pressure. I think in the morning, my talk in the morning has already mentioned about the non-selective beta blocker in the treatment of portal hypertension. However, only half of the patients respond to beta blocker treatment. So in the past several years, many investigators have tried to add other pharmacology agent to propranolol to see whether there will be an enhance of the portal pressure reduction. However, these studies show that some of them are not achieve this goal, and the others may cause a further decrease in mean arterial pressure. So this combination therapy has not been clinical use. 20 years ago, it had been shown that carvedilol may be have potential to be the treatment of choice in portal hypertension. In this study, carvedilol have been shown to be more effective in decreasing HBVG in patients with cirrhosis. And also, we can see the mean arterial pressure is also decreased. And in our study, we found that carvedilol is more effective than propranolol plus isosorbide mononitrate in reducing the HBVG. We also found that when using carvedilol, the hepatic blood flow is increased using carvedilol. This suggests that the carvedilol may have a role in the decrease of the intrahepatic resistance. Several years ago, statin has been also tried to assess in the pharmacological treatment of portal hypertension. Statin, although statin had no direct vascular effect, but they may have improved the potentiated nitric oxide bioavailability in the liver, so may decrease the intrahepatic resistance. These hemodynamic studies show that the use of statin may decrease the HVPG, and also particularly in those with the previously non-selective beta blocker usage. And this study showed that non-selective beta blocker plus statin may have greater decrease in the HVVG, although the case number is small. Because statin may be decreased portal pressure, so carvedilol has been tried to evaluate the addition effect of carvedilol to simvastatin in patients with cirrhosis. This group from India with a large number of patients receiving hemodynamic study. Unfortunately, this study failed to show the additive effect of simvastatin to carvedilol. This possibly due to the carvedilol has a direct alpha adrenergic blocking effect in the intrahepatic resistance, which may mask the starting the effect in the, based on the increased nitric oxide bioavailability. In addition to evaluate the pharmacological effect, assessing the HVVG may also have some role in to study the pathophysiological status of cirrhosis. Many years ago, they have found that there is a circadian variation of portal pressure observed in patients with cirrhosis. This is probably that we clinical seeing that variceal bleeding is often occur during the midnight. We also found that our study and other study also found there's a postprandial increase in hepatic blood flow and HBVG in patients with cirrhosis, and this phenomenon can be ameliorated by propranolol and octreotide. And in the pathophysiology status, we found that the increased oxidative stress and inflammatory cytokine correlate with the degree of HVVG, and also the anemia, presence of anemia may also exacerbate the severity of hyperdynamic circulation in patients with cirrhosis. So in addition to the evaluate the pharmacological treatment, measurement of HVVG can also assess the pathophysiology status of cirrhosis. This slide was also shown this morning from the Professor Garcia Charles group that in patients without ascites for using non-selective beta for primary or secondary prophylaxis, it is clear show that the responder has a better outcome for any clinical event or death of transplant. And this is also occurred in patients with ascites. So clearly the portal hypotensive effect of the non-selective beta blocker is a well-established phenomenon. On the other hand, we can see that the patient with cirrhosis may also need to undergoing some elective extrahepatic surgery due to other diseases. We all know that the surgical procedure is a stress condition to patient with cirrhosis and may lead to the development of a decompensation. And this slide show from the Barcelona group show that if the HBVG preoperative HBVG greater than 16 millimeter mercury, the post-surgical outcome will be increased dramatically. So before surgery, probably we should aim to decrease the HBVG pharmacological treatment. This study from the Japanese group showed that in patients receiving living donor liver transplantation, if the HBVG greater than 16 millimeter mercury, there will be increased risk of small foci syndrome in this patient and lead to the graft loss. So when doing the transplantation, measurement of HBVG may also help to improve the outcome. As HBVG measurement is still an invasive method, so many investigators have tried to find the non-invasive test to evaluate the degree of portal hypertension in patients with cirrhosis. Unfortunately, regular serum biomarker, conventional ultrasound all fail to replace the HBVG measurement. In our recent study, we have found that the IOP score can be better correlated with HVPG. However, we can predict significant portal hypertension and severe portal hypertension, but the correlation coefficient is still not high enough to accurately predict HVPG. Elastography has been used as a non-invasive method for evaluation of portal hypertension. Transient elastography have been used for long term, and the current meta-analysis have shown that transient elastography, the liver stiffness measurement, can well reflect the presence of clinical significant portal hypertension. However, there's no linear correlation with the HPVG, particularly when the HPVG was greater than 12 millimeter mercury. It is clear that when the portal hypertension becomes more severe, the hemodynamic change is not solely depends on the stiffness of the liver. There may be other factors that contribute to the hemodynamic circulation, hyperdynamic circulation. In addition to the non-linear relationship for the liver stiffness measurement and the HPVG, their study also found the liver stiffness measurement did not mirror the changes of HPVG in patients receiving non-selective beta blocker. In this study, we can show that the beta blocker responder, the HPVG is decreased while the mean liver stiffness measurement is increased. In this study, also show that there's an increase and also a decrease in liver stiffness measurement after non-selective beta blocker. So liver stiffness measurement is still not a reliable non-invasive modality to reflect HVPG. Recent studies show that spleen stiffness measurement may be a potential modality to correlate with the HPVG, and this study showed that the HPVG, the spleen stiffness measurement increased with the severity of the portal hypertension. And after TIPS insertion, the portal hypertension was relieved and the spleen stiffness was gradually decreased with time. A Korean study have found that spleen stiffness measurement in patients receiving carvedilol, and they show that there's a rather good correlation between the hemodynamic responder to non-selective beta and the splenic stiffness measurement, and derive a formula to calculate the correlation. However, this formula is rather complicated, and for the clinical practice, spleen stiffness measurement is not as easy as the liver stiffness measurement. So the use of spleen stiffness measurement to reflect the HVPG may be need further evaluation. And a recent study showed that the measurement of using the quantitative MRI in assessment of portal hypertension show a very good correlation. The correlation coefficient can reach 0.9. However, the MRI measurement is very cost and is very expensive, and the MRI is not equipped in every hospital. So the clinical implication of this assessment is still not widely applied to every hospital. So, ladies and gentlemen, it is concluded that cirrhotic portal hypertension may lead to the development of systemic and splenic hepatidemic alteration and associated with bacterial translocation, and these changes ultimately result in systemic inflammatory multi-organ syndrome. HVPG measurement is still the gold standard in assessing the severity of cirrhotic portal hypertension, and degree of HVPG has profound clinical implication, and reducing HVPG provide a significant beneficial effect in patients with cirrhosis. And there's a heterogeneous is high across the non-invasive diagnosis tool, and non-invasive quantitative assessment of portal hypertension is still a major unmet need in the field of chronic advanced liver disease. So thank you very much for your attention.